ever since. So, in terms of PAD, I think in the hospital setting, as PAD can be, a combination of asymptomatic or claudication is the way I think about it. But really what we're concerned about in the hospital setting is patients with CLTI or chronic limb-threatening ischemia. So what is that? So peripheral arterial disease, by definition, implies an atherosclerotic process. And if you're to get an ankle brachial index, it implies that it's less than 0.9, or another way to look at that is less than 90% of normal. So it's a pretty low bar, but that doesn't mean that this is something that is benign, because when it becomes more severe, we put these patients into a different category, which used to be called critical limb ischemia. I guess you can still call it that, but at least how we term it and refer to it now is chronic limb-threatening ischemia, or CLTI. And what that implies is there's objectively documented PAD, such as with an ABI or other imaging, and then you have one of three things: ischemic rest pain present in the patient, an ulcer such as a diabetic foot ulcer or any other ulceration present for at least 2 weeks, so a non-healing ulcer, or gangrene, which is pretty self-explanatory. I think ulcers and gangrene, you can tell what that is. Ischemic rest pain can be a little trickier. The classic patient presents with pain in the foot. Typically they'll say it hurts at night when they're lying in bed. They have to hang their foot off the side of the bed to get dependent flow and improve their pain. Typically it's on the dorsum of the foot, near the great toe, in between the first and second toe, in that web space most commonly, and it's due to an ischemic neuritis. So these patients, they may not have a wound, but typically or classically they'll have an ABI less than 0.40. If you can get an ABI, and I'll get more into that later, simply an ankle pressure less than 50, a toe pressure less than 30, or transcutaneous oxygen pressure, if you have access to that, less than 20. All of those would be consistent with ischemic rest pain. And why? Why should we care about PAD and or CLTI? Well, essentially PAD is a surrogate for coronary disease. PAD affects over 10 million people in the U.S. alone. And as you guess, the risk factors are the same for atherosclerosis and other vascular beds. So patients with PAD are at risk of MI and stroke. They may have been undiagnosed or underdiagnosed in terms of their cardiovascular health, and this leads to a mortality risk, of course, as well as a risk of limb loss. I should specify that in terms of peripheral arterial disease alone, so in the absence of limb-threatening ischemia, so no rest pain, no tissue loss, the risk of amputation is actually less than 5% in 5 years with a diagnosis of PAD. But if that same patient now has a non-healing ulcer or ischemic rest pain, their risk of major amputation is up to 25% in 1 year. So significant difference when we're talking about just a patient with PAD or a patient with PAD and CLTI. As with painful ulcers or rest pain, this can be a source of pain and thus diminished health-related quality of life. What PAD or CLTI is not, or at least what I'm not going to be talking about today, are venous ulcers, traumatic peripheral vascular injuries, acute limb ischemia, typically an embolic or thrombotic phenomenon. You may remember your 6 Ps, and that's not what we're talking about, because that's a surgical emergency. So they have pain, pallor, pulselessness, poikilothermia. paresthesias, and late paralysis. So that's a surgical emergency, and that's a little different than patients with PAD or CLTI, which imply a chronic condition. And then there's non-atherosclerotic etiologies of peripheral vascular disease, including vasculitis, Berger's disease, radiation, arteritis, et cetera, that I'll not be covering this morning. I just bring up this document just to note that while this is a very large document, it's a valuable resource for evidence-based guidelines on the treatment of CLTI in patients with PAD, and in particular patients with foot wounds. So this is a combined effort of vascular societies, podiatric societies, looking at patients with threatened limbs. And so a lot of the recommendations I'm referring to come from this practice guideline. So starting with the patient history, I think it's helpful to have an understanding of the acuity of the current presentation, whether it's pain in the patient or a cold foot or previous wounds, how long have those wounds been present, what's been done to treat those wounds. Clarifying claudication symptoms. Is the patient ambulatory? Can they walk enough to produce claudication? A bedbound patient obviously cannot. So what's their functional status? Do they have the ability to get around? Are they walking with a cane, et cetera? Because some patients just don't have the energy, or due to frailty, they're not getting around enough to produce claudication symptoms, and thus you may not think of PAD. Rest pain, as I discussed, and again, rest pain is not just my legs hurt at rest. It's really should be a focal thing, and often I'm seeing patients that in order to sleep at night, they're on opiate pain medicines, or they're sleeping in a recliner with their feet down, or the classic presentation of they wake up, they hang their foot off the bed, or they get up and walk around and it feels better. It's always important to review their comorbidities or risk factors just to have a sense of what's contributing to this. Smoking, of course, being the number one risk factor, and I always make a point to inquire on what their cessation efforts are, who's helping them with that, how we can help them with that, and have they picked a quit date. Understanding where they're at, if they carry a diagnosis of diabetes, such as when was the last time they had their hemoglobin A1C, are they being managed for hypertension or dyslipidemia, what's their prior history of vascular disease in other beds, such as coronary disease or cerebrovascular disease, history of stroke, et cetera, or congestive heart failure. Helpful to know if they've had prior vascular interventions. I know sometimes that's hard to find out, and patients may not recall what was done or what stent was placed where, but it's helpful to know in terms of your index of suspicion. And chronic kidney disease or end-stage renal disease, unfortunately we see a lot of patients with this, both PAD, diabetes, and chronic kidney disease, and particularly the patients on dialysis, I should mention, are really the bad actors. So if you have a diabetic patient with PAD and end-stage renal disease that has an ulcer, that can turn to gangrene quickly, in days. So those patients just really need close attention when they're developing lower extremity ulcers. In particular, obviously the patients without kidney disease but just with diabetes are at increased risk, as you know, because if they have PAD and a diabetic foot ulcer and they don't heal that, they're going to be at higher risk of major amputation. I bring this up just in terms of in reviewing these cardiovascular risk factors. It can give you a clue of the distribution of their arterial disease. For example, smokers may have more of a preponderance of aorta-iliac occlusive disease or femoral popliteal disease, whereas diabetic patients often present with tibial disease, which takes into account, sort of how we treat them, what we expect to find. And I also bring this up in the context of the physical exam, which I think I'll get to next, in which something as simple as a femoral pulse, not just looking for pulses in the feet, can give you a clue about the contribution of aortoiliac occlusive disease as a contributing factor to their symptoms of atherosclerosis. So best medical therapy for patients with PAD. This may look familiar, as it's going to be very similar to your patients with coronary artery disease. So currently, best medical therapy includes antithrombotic or antiplatelet therapy, which can be aspirin, Plavix, or ticagrelor. There's not a strong recommendation from the surgical societies on this, but there is a benefit shown with low-dose aspirin, so 81 milligram aspirin, and low-dose rivaroxaban, the 2.5 BID dose that is indicated for peripheral arterial disease. In my practice, it's really the patients with CLTI or PAD that have undergone intervention where this has really proven to be beneficial. However, as you've probably experienced, some patients may have trouble getting this paid for, and in which case, in those patients post-intervention, aspirin and Plavix is kind of the go-to, whether they're having a surgical bypass or a stent in their leg. We'll often be putting them on that post-operatively and maintaining that for at least three months, if not indefinitely. There is a benefit in PAD patients for moderate to high intensity statin use, which reduces their all-cause cardiovascular morbidity and mortality. And this increases in patients in terms of the benefit in patients who've undergone intervention. So in patients that I'm taking for surgery, even if their lipids are normal, we're putting them on a statin unless they've demonstrated intolerance in the past. Recommended antihypertensive therapy, of course, and tight glycemic control, shooting for a hemoglobin A1C less than 7%. So in the elective outpatient setting, that's our goal. Sometimes in the inpatient setting, we don't have time to wait for that to come around, obviously, but having an idea of where the patient is coming in is still helpful. Smoking cessation, of course, being the number one risk factor, is recommended, and as you know, a combination of pharmacotherapy, counseling, or behavioral modification therapy is recommended. In these patients, particularly elderly, frail patients, I think dietary counseling can be important, especially if they're looking forward to an operation or they're recovering from an operation and they have higher metabolic or higher caloric needs than they would otherwise. And some patients don't understand that if they're preparing for surgery or recovering for surgery, that their body needs more, even if they're not hungry. In terms of best medical therapy and exercise, an exercise program of at least 30 minutes a day, at least 3 times a week for 12 weeks as an intervention prior to surgical therapy in PAD patients. So this is not the CLTI patients, because you can't make someone walk around with ischemic rest pain or a wound on their foot, because that just wouldn't be good. So, however, depending on where you are, you may find difficulty either patients following through with this, in which case a supervised exercise program is nice if you have access to that, such as in a cardiac rehab program. Insurance will pay for this for the diagnosis of PAD, but it varies by region. And so I just emphasize this to patients in person, not just sending them somewhere to do exercise, but that it's as simple as getting out, walking. It doesn't have to be anything fancy, and that if they can't do 30 minutes at once, they walk until they have pain, they stop, and then ideally they walk again. And then I tell them the next day the goal is that they don't walk less than the day before. As well as some patients may need to break that up, like 10 minutes in the morning, 10 minutes later, to get a total of 30 minutes in a day, or if they have access to a treadmill, that's a helpful way to keep track. And then in terms of preventative foot care, particularly in patients that can't see their feet or can't reach their feet for a good foot examination, is particularly important for these patients to have a thorough foot exam, as well as in the diabetic patient, a diabetic foot assessment once a year, including a filament test to assess for neuropathy. Laboratory evaluation, particularly important in the inpatient setting. Obviously, we want to know if there's lab abnormalities, but I think things that are important, evaluating for things that are going to increase their risk of surgery if they're coming in anemic. Why is that? If they have a leukocytosis, do they have uncontrolled infection, in which case in the patient with a non-healing wound or gangrene, we may be offering them a drainage procedure or even an amputation for source control of infection before any arterial intervention is done, because we want to get them through that initial inflammatory phase before doing a revascularization. Chronic kidney disease is particularly important in the workup and where they're at, because this may affect our imaging modalities or our treatment modalities. We may or may not be able to give IV contrast, for example, for a CAT scan or for an angiogram, and may need to think of things more creative, like using carbon dioxide for angiography or intravascular ultrasound to avoid contrast. And as I mentioned before, they're a nutrition lab, so we have an idea of where they're starting and what their healing potential is if they are to undergo a major vascular reconstruction or amputation. So my typical physical exam on these patients is obviously a pulse exam in addition to a thorough head-to-toe exam, but focusing on the vascular exam, I'm checking radial pulses. I want to know their bilateral brachial pressures. These patients with atherosclerotic risk factors have risk of subclavian artery stenosis, so they may have a brachial pressure gradient between one arm and the other, and maybe we're using the wrong one. Feeling for an aortic pulsation, as these patients are also at risk for aneurysm disease. The femoral pulses I mentioned will give us a clue about possible aorto or iliac occlusive disease. The popliteal pulse will give us an idea of level of disease, as well as I think for folks that aren't feeling popliteal pulses very often, if you do feel it, that makes you worried for a popliteal aneurysm if you find those pulses difficult to find. So if a prominent popliteal pulse might clue you in to a popliteal aneurysm. And then, of course, pedal pulses in the dorsalis pedis distribution or the posterior tibial distribution, so right on the top of the foot or behind the medial malleolus. And documenting that is important because it doesn't always get documented, and that if you have access to a pen Doppler, whether you're able to obtain Doppler signals and those distribution is helpful. Wound pictures and measurements are helpful. I have patients send wound pictures all the time, and probably those of you that also are involved in wound care, this is important for documentation and progression of wounds. So a wound that's getting smaller and smaller is a good sign and lowers our concern for poor perfusion leading to this, but pictures can be very helpful. And then, of course, assessing their functional status and their level of frailty. This isn't typically always possible in the hospital, obviously, to get patients to stand up, walk around, come back, sit down But that's what I do in the clinic in patients that, we're considering a major vascular reconstruction and we need to see how well they get around. I used to have colleagues that have patients walk the stairs in their clinic or in the hospital, but that's probably not the best recommendation because that's not where you want to have a rapid response or a code, which sometimes happens in the vascular clinic. So the vascular lab evaluation, you may or may not have this available to you. However, I would argue that if you have a Doppler and a blood pressure cuff, you can get an ABI. So even without a waveform or specialized vascular lab, that can be done and can be useful information. A normal ankle brachial index, so the brachial pressure, as the denominator and the ankle pressure as the numerator should be between 0.9 and 1.2. So we mentioned PAD is less than 0.9, critical limb ischemia typically less than 0.4, and severity of the claudication runs in between somewhere. However, that doesn't mean that someone who has an ABI, like this patient seen here, of 0.8, for example, in this exam, has claudication. It's consistent with it. We may expect to find that in a patient who presents with those symptoms, but we start with the symptoms and then go to the imaging as opposed to the other way around as far as what conclusions we can draw with that. Particularly in diabetic patients, they may have calcified vessels due to medial calcinosis. So an ABI may be falsely elevated. Typically, if it's greater than 1.3, we don't trust those values. However, a vascular lab will also give you a waveform, so abnormal waveforms, and a falsely elevated or a non-compressible ABI is an unreliable test, so you don't have any idea what their perfusion is because of that. But typically in diabetics, the digital vessels are spared of the medial calcinosis in most patients, so you can get a toe pressure and a toe brachial index. A toe brachial index less than 0.7 is consistent with PAD, so that can be a helpful way to get an objective form of perfusion to assess their wound healing potential. Photoplethysmography, an example of these photoplethysmography waveforms is there on your screen right, showing pulsatile waveforms. So in patients with non-compressible ABIs, this can let us know, do they have evidence of pulsatile flow in the toes or not. Laser Doppler is something we use as far as assessment for wound healing in patients that have a non-healing wound or maybe getting prepped for amputation. And transcutaneous oxygen pressure is not widely available and is a little bit more variable, in my opinion, to the laser Doppler. But those are numbers where we're basically getting an idea of what's the perfusion at the level of the skin, and we can do it at different levels, like at the toe, the midfoot for a possible transmetatarsal amputation, or the calf for a possible below the knee amputation, and gives us an idea of the chances of healing in those patients. I've listed the arterial duplex below all this for a reason, in that I often see or I often get called with the results of an arterial duplex, but which gives us anatomic and somewhat physiologic information. It lets us know there's a stenosis or there's an occlusion. But in the absence of knowing the patient's symptoms or doing an ABI, it may be meaningless because not every occlusion needs treatment and not every occlusion is significant. So by routine, when I get an arterial duplex or at the vascular lab at OHSU, it comes with an ABI automatically, even though that's technically a separate test to order. I would encourage you that if you have access to an ABI or even a toe pressure, that gives so much more information than a duplex alone, which again will give you evidence of occlusive disease, evidence of stenosis, but in the absence of correlating that with symptoms or an ABI, it's really tough to tell. I list here vein mapping, and that's referring to saphenous vein mapping in the event a patient with PAD or CLTI needs a bypass. Recently, in the New England Journal, the BEST CLI trial demonstrated in patients with CLTI that have a single segment of saphenous vein adequate for a bypass will do better with bypass than with endovascular interventions, which we've also seen in practice for years. In terms of axial imaging, CTA and MRA can be considered. Drawbacks, obviously, iodinated contrast and the radiation. I would also encourage you that if you're concerned about a wound or a leg and you're getting a CTA, get both legs, get the aorta as well, because as I mentioned with the incidence of aorta-iliac occlusive disease, that if all you have is from the femoral head down and one leg, that limits our ability to know, how we can treat the patient, particularly if we're doing an angiogram. We want to know the status of the femoral arteries bilaterally as well as the iliac arteries. So if the patient's going to get contrast, they're going to get radiation. It's not saving them anything to just take a picture of one leg. And in terms of the MRA, one limitation to that is you're not going to see the calcium as nicely as you see on this CTA image, and that can be helpful for surgical planning, not so much as far as determining, the existence or severity of disease. But the other thing I'll mention is that with calcium, particularly in the tibial vessels, which is the farthest the contrast has to go, a CTA may be limited, so you can't really tell what's happening in some cases below the knee. In which case the gold standard is still angiography or digital subtraction angiography, which this shows, so the bones and soft tissues are subtracted out. In patients with CLTI, it's important to have high-quality imaging with dedicated views of the foot and ankle so that we can do anatomic staging and procedural planning. And if we're collaborating with our podiatric colleagues, they want to see the foot too. They want to know what the perfusion is like, not just the occlusion that we've stented or bypassed. I mentioned this just at the end here, a classification for CLTI where we're taking into account the stage of the wound, the stage of the ischemia, and the presence or absence of foot infection can be useful in predicting amputation. And this is a Wi-Fi stage. But as we're running short here, just to wrap up, I think doing things in order is important. So the history and physical exam first, reviewing their risk factors before pursuing imaging and getting an ABI with ultrasound imaging. If you do not have ultrasound imaging, axial imaging can be very helpful so that you can assess the patient even though they're in absence of those resources. And then, again, emphasize the importance of angiography prior to revascularization, including vein mapping prior to. And as I mentioned, if you have a patient with an infection, that's something we're going to want to control. Despite the presence of peripheral arterial disease, we want to control that prior to revascularization. I really appreciate your time and attention this morning and your patience with working through these slides, and I'll look forward to your questions with our panel.